It was the email that came out this afternoon with the agenda.
This afternoon?
Yes, this afternoon.
Yeah, I didn't receive that, nor did I receive the RSVP. I mean, I'm looking through both of my parts of my email, so I don't know if there's a glitch in the system, but I'm hoping you could send it again.
I can't. Maybe, I'm so sorry, but maybe Deanna can.
Which email would you like us to send it to?
The Knox County one is the one I have pulled up right now. I have to close the account to go between accounts between UT and this one. So I've got the Knox County one open right now. Thank you.
Okay. Yes, we'll get it to you. And
Thank
Dr.
you.
O'Brien, I see that you're on. You want to do a quick audio?
Can you hear me clearly?
Yes, we can. Thank you.
Okay. Thank you, Narda.
You're so welcome. I'm glad you got it.
Did you call my name? Hello?
Yeah, what'd you say?
No, I'm off. Bye.
All right, see you later. Bye.
Well, the phone clock says it's 5 o'clock, so I think we should go ahead and start our meeting. So I want to welcome everybody to the Knox County Board of Health meeting for today, August 19th. And so we'll have a call of order of the meeting, and then the next item on our agenda is a roll call. So Narda, if you are available, if you will go through the roll call for us, please.
I'll be doing that this evening.
Oh, thanks, Martha.
Sure. So Dr. Drake,
Yes.
Dr. Goetcher,
Here.
Mayor Jacobs,
Here.
Dr. Hurt,
Here.
Dr. O'Brien,
Present.
Dr. Shamia,
Here.
Dr. Souza,
Here.
and Ms. Wagner.
Present.
All right, and I'm present also.
So with all members present, we do have a quorum. And the next item on our agenda is approval of the minutes from the August 12th meeting. And I know that Dr. Hurt was working on getting a copy of that, but has everyone gotten a copy of the minutes and had a chance to look over those minutes from the August 12th meeting? If so, are there any, pardon?
I move they be accepted.
Okay, any additions? Well, let's have a second on that.
Second.
Okay, and then any additions, corrections, substitutions that we see or any discussion arising out of that? If not, I'll call for a motion to approve the minutes as distributed. And I need a motion and a second on that.
So moved. Second.
And Dr. Buchanan, if you'll do a roll call on that for us, please.
Certainly. Ms. Wagner,
Yes.
Dr. Souza,
Yes.
Dr. Shamia,
Yes.
Dr. O'Brien,
Yes.
Mayor Jacobs,
Yes.
Dr. Hurt,
Yes.
Dr. Gocher,
Yes.
and Dr. Trick.
Yes.
Passes unanimously. Thank you.
Thank you. The next item after approval is to set the agenda. And does everybody have a copy of the notice and agenda for this afternoon's meeting? If so, I'll entertain a motion to accept the agenda as printed, and we'll need a second.
I'll make a motion.
A second.
So we have a motion and a second for setting the agenda. Any discussion on the agenda? If not, Martha, if we'll do a roll call on that as well. Thank you.
Sure. Dr. Drake,
Yes.
Dr. Gocher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
and Ms. Wagner.
Yes.
Thank you.
Thank you. Having set the agenda, the next item on the agenda, item 6, is Knox County Health Department benchmark presentation by Dr. Buchanan.
All right, so Catherine is going to pull up the benchmarks for us all to be able to see. While she does that, I'll just run through the local situation for today. Today we have 45 new confirmed cases of COVID-19, giving us 5,528 confirmed cases of COVID-19 since March. Additionally, we have 203 probable cases. 3,482 cases have recovered, giving us 2,197 active cases. 239 individuals have been hospitalized at some point in their illness. 39 Knox County residents are currently hospitalized. And we report one additional death related to COVID-19 today, bringing our total to 52. So that's always sad for us to report. So for our first benchmark, cumulative case counts, looking at our benchmark is sustained reduction or stability in new cases for 14 days. We did not see flags, which indicates a stable or decreasing trend. However, we are still seeing an average of around 88 cases per day. While we are still representing this benchmark as yellow, the lower volume of new case counts we have seen over the past 14 days is encouraging, and we hope that continues. It is a plug for everybody to continue to do the 5 core actions. They're working. So our second benchmark, community-wide, sustained and increased diagnostic testing with consistent or decreased test result reporting turnaround time. From the data, we can see the trends are heading in the right direction. The number of tests conducted continues to trend consistently, and the lab turnaround time in our community also remains consistent. The average turnaround time in our community is 2 days or less at this point, which this is encouraging, and this benchmark is green. Third benchmark, sustained or increased public health capability. We continue to be able to attempt and usually contact most cases within 24 hours and close contacts within 48 hours. Because of that, this benchmark continues to be represented as green. Fourth benchmark, healthcare system capabilities remain within current or forecasted surge capacity. This benchmark continues to be represented as yellow. We did experience a day of statistically significant increases regarding positive patients, but there were no flags noted for ICU patients or ventilated patients. And as always, these decisions regarding how to classify this benchmark as green, yellow, red are made in concert with our hospital partners and taking all the data into consideration. Our fifth benchmark, sustained or decreased COVID-19 related death rate for identified positive or probable cases. this benchmark is represented as yellow. As a note, over the last 14 days, we've had 11 deaths reported compared to 17 in last week's benchmark. So though we continue to see deaths, the rate has decreased slightly. So we're encouraged by that. Any questions about benchmarks?
Dr. Buchanan, I just have one question about data in general, and you may have addressed this in a press conference yesterday, but for college students who live in another part of the state or even another state, but they reside in Knox County when they're going to school, and if there's a positive case, where does that go in the data?
That person, as long as if they stay in Knox County and they were in Knox County when they were diagnosed and they're living here, they are counted as a Knox County case. Now, if they live in a different jurisdiction and decide to go home to recover, then that will be transferred to that jurisdiction. If they live in a different state and decide to go home, they'll be transferred to that state and count as their case count and come out of our case count. We do this pretty regularly. UT students who live here and stay here are going to be counted in our case count.
Okay, thank you.
Sure. Any other questions?
Any other discussion on benchmarks?
Dr. Gocher, you're muted.
Sorry. Was there any other discussion on point 6, on agenda item 6, which are the benchmarks? Any other points of discussion from anyone?
So I had one other question for Dr. Buchanan, and that is that it's related to, we don't have to go back to the benchmark, the data, but I talked last week about the importance of contact investigation, particularly when things, as I think what I said was, it's contact tracing and quarantine is not a great way to get things under control. It's a better way to keep things under control once they start to go down. I don't know is that a fair statement, Dr. Buchanan?
That's a fair statement, but I also think that there are tools to help us get things under control as well. I mean, they help, but they're not, they're not as effective as keeping things under control.
That's a better way to state it than the way I said it. It's got to roll across the board. I think my question was that when you to me, that's pretty straightforward when you think about a school, for example, knows which students were in class. A workplace knows who was there on a given day, who wasn't there on a given day. How much more complicated is that for situations where it's more of a public space, or if it's something that's not just discrete about knowing who was there at a given time? Is that just a lot more complicated, or are you able to generally navigate it with knowing who to call and those type of things in the same way when it's not as clear who was there at a given time? Does that make sense?
Yes, it does. And certainly when there are more factors that can change in an environment, that makes contact tracing even more challenging. The couple of things that are helpful with that with COVID is that we don't have to go back very far. If you're taking a case history from somebody with some other illnesses, you might have to go back 30 days. We only have to go back 2 days for COVID from the onset of their illness. So that's helpful because that helps us they don't have to remember as many days of who they were with and what they were doing. We are really reliant on people telling us that information and giving us that information. So sometimes there certainly are gaps. People forget, oh yeah, I was at that place and Sam was there or whatever. So that certainly is going to happen. But it does add some nuance to it. The other thing is that you need to have contact with Sam for more than 10 minutes and be less than 6 feet away from him. So that helps too, because that's not just passing somebody by in the store. Passing somebody by in the store is not how you're going to give them COVID. It's stopping and having that conversation with somebody at the store without your mask on is how you're going to give somebody COVID. So those 2 things help make it a little bit easier. I don't want my staff to hear me saying it's easy, because it can be very complicated because people do a lot of things that are in a lot of places. I mean, if we all take time to think about who we've been around in the past 48 hours, the list gets long pretty quickly. So.
Okay, and thank you. And just to be clear, because when you clarified what I said, you said it much better. I do not want to imply to anyone listening that, I mean, there's a role for contact investigation and appropriate quarantine, regardless of what stage we are in tracking this illness. It may just be at different levels of effectiveness depending on how much disease there is in the community. But I don't want to send that message at all. So thank you for clarifying and restating what I said.
Thanks, Dr. Shmaya. Any other points of discussion on our benchmarks? So, one observation is that our benchmarks have maintained or have improved over last week. Last week, our benchmark 5 was red and it's yellow now. I mean, we still are having deaths, but that rate seems to be going down just a little bit. So overall, I'd say that's a favorable last week. We'd like to see everything in green, but it's probably not going to happen soon. If there's no other discussion, we'll go on to item 7, which is University of Tennessee Medical Center Knoxville's data update. Dr. Shmaya?
Yeah, thank you, Dr. Gocher. So this will be, I think, pretty straightforward and consistent with what Dr. Buchanan said. So just go ahead to the next slide, please. So this is the same correlation. It's right now kind of leveled off at somewhere between, this was similar last week, between 42 and 44 new hospitalizations per 1,000 cases, and the correlation remains strong. Next slide, please. So getting to that case piece and just looking at it a little bit differently from a hospital perspective, on the left in Knox County, this is consistent with what we mentioned last week, which is starting to be favorable. That if you look there, again, it took us 113 weeks to get to the first 1,000, 15 weeks to the next 1,000, then 9, then 8. And actually, we thought it was going to take 10. It took us 11 weeks to get to that final 1,000. So we want to see that number continue to get bigger and longer to get that next 1,000. The Knoxville district is kind of just hovering around that same 4 to 5 weeks for that additional 1,000 of all those counties. Yeah, that's right. Yeah, I think Dr. O'Brien. So this is the number of days to get to that next 1,000. I may have misspoken. And so let me clarify, 113 days for the first 1,000, 15 days for the next 1,000, 9 for the next 1,000, 8 for the next 1,000. And we thought it was going to take 10. It took 11 to get to that next 1,000. Thank you for that. Next slide, please. So this is also kind of showing that downward trend in terms of the number of new cases by week and month. We showed at Knox County how it was 763, then 889, then 665, and then 610. So certainly not the same degree of drop that we'd seen last week, but still dropping instead of going upward. Next slide, please. So this is that doubling rate that we've shown over the last few weeks, and just timed by kind of the whether it's coincidental or not, by the focus on the 5 core actions, although that's been focused on the entire time by the health department, but also the focus on masking. We want to continue to see this go down, and so this is exactly what I would think we want. This is the first thing that we saw start to improve before we started to see improvement in cases. And so that trend continues. Next slide, please. This shows the same data as far as new cases, but puts us in context of Davidson and Hamilton and Shelby. Shelby has actually now seen at least a couple weeks of consistent improvement. Davidson and Hamilton have started to inflect upward just a bit. So their case rate, I wouldn't call it dramatic by any stretch, but their rate has increased. And then on the right, Knox is what I've already shown you, but that shows that downward trend, not as dramatic as it was, but shows the downward trend. Next slide, please. So then to wrap up, the last few slides talk about hospitalizations. Knox County is shown, again, these are, the people who are attributed to Knox County. There is a decline in those hospitalizations, whereas the district is more level across the board. And then over on the right, you see the number of hospitalizations in August to date, both in the county and the district. So it's hard to know exactly where that'll land in the next 12, 13 days, but it seems like overall August will be a comparable, maybe slightly less, but comparable month to the month before. Next slide, please. And then finally, so that was the number of new hospitalizations. This is the census. This is the number of patients in the hospital at any given time across those all of those counties. And as I've mentioned before, sometimes there's issues with reporting. If one or two hospitals don't report on a given day, it can affect the data. But you see that we peaked there at that 185, and it's been a little bit jagged up and down, but is now at 145 most recently. Next slide, please. And so this is, again, this is now through Labor Day, but remember that we're getting closer and closer to Labor Day. And so I believe the next time I show this, the intent would be to project it out to the end of October. So it'll be a little more useful, but that just shows kind of that leveling off of, if you recall, when we presented this initially, there was that line went up and to the right as far as the projected hospitalization, and in the last few weeks, it's really leveled off. Next slide, please. And then this was getting too busy to show every single projection that we've done since the beginning. And so we're going to start showing just the last 2 or 3 projections. I think that it's also the software is not able to keep laying projection over projection. But there you see the green line is our current trend line I just showed you. And then the last week, it was really diving and it's kind of leveled off a bit, but more similar to what we had on August 5th and certainly still more favorable than what we were looking at a few weeks ago. I'll show just a few of these, but if ever historically anyone wants to know kind of, hey, what was the prediction going back at a certain date, we can easily be able to show that. So I believe, next slide, please. I believe that concludes what I've got. I misspoke there in the beginning. So if I create any confusion that I didn't clarify, you guys please jump in and help me get it straight. And I'd be happy to take questions.
Any other questions, comments?
I have a question. This is Dr. Hurt. Thank you for the presentation and the information, Dr. Schmidt. Can you please explain for our viewers who contact us, email us, and I want to say thank you again. I try as best I can to read emails and feedback from my fellow citizens, as I know my colleagues here do. But there is, I've received feedback from people who say, now that the numbers are going down, we don't need to have, let's say, a face mask regulation anymore. And so I'm wondering if you would, just for clarity's sake, once again, and I know we've addressed that and we've talked about it, but I think it's a good, important message to keep clarifying and reinforcing for our viewers and people who don't or cannot view this, but of course know the decisions we make, which are based on the data. Can you, would you be so kind as to once again revisit the significance of those numbers dropping, but why we should continue to observe the 5 core actions, including wearing masks? Thank you.
So yeah, I'll be happy to do that. I may not be the only I mean, certainly that's, I think, open after I speak to anybody who wants to address it. Remember, first thing is we talked about all of the lag in the data. and that and the behavior of the virus and the way it affects that. First, you start to see the more additional cases, and then you start to see more people being diagnosed, then potentially more people in the hospital, and then ultimately the ultimate lagging indicator are whoever dies. And so the only fundamental thing that I see in the environment, and again, this is based on my medical training and my clinical background and my specific clinical background and understanding what I do about how the virus behaves, is the reliance on the 5 core actions. And I've said it before that I feel like mask wearing is fundamentally important to that. And so to me, the timing of where we started to see this improvement, and we're seeing, I mean, there's undeniable favorable trends in the data. Not quite as dramatic this week as what we saw last week, but I mean, this is exactly what I would have hoped to see as we embark on schools and things like that. And so there's no other thing that I can see that would have led us in that direction based on my understanding of the virus. And so to me, if it's going in the right direction, and we know we have these additional things that are happening around us, the very important things related to educating our young people, but that naturally involve a lot more mixing of people, that, I mean, it's so fundamentally important to continue the emphasis on the 5 core actions and on masks, because to me, that's not only part of what protects the hospitals down the road from that spike that I was very concerned about, that projected number in September 9th and beyond, so that we were concerned that there would be some services we might not be able to deliver to take care of sick patients, but also just to be able to try to do our best to do these other things that are new in the system that are very, very important from a societal standpoint. So I view this as cause effect, and because it's working, to me, it makes sense that we've got to keep doing it, because if we relax, we're just going to go right back up, and maybe even more than we did, because the system is different now. Our environment is different now than it was when we talked about this 4 or 5 weeks ago. Does that answer your question?
I have a question to either Dr. Chimay or Dr. Buchanan. Are there established changes in positivity rate that trigger a tightening or a relaxation of any restrictive measure?
I'll defer that initially to Dr. Buchanan.
Sure. To my knowledge, there are no like set values of positivity rates where if your positivity rate is this, you should do that. There are communities that are trying to do that and use that as a really one benchmark, but there's so many variables that impact the positivity rate, the number of people getting tested, the availability of testing, all of those things. So that's why we've chosen to look at lots of different things. In addition to that, our positivity rate is one of those pieces of data that is a little harder for us, the health department, to get. We know the positivity rate for the people we test, but the community-wide positivity rate is a little harder for us to assess. As we talk about on the benchmarks, the testing data is really just a sample of testing that's being done. We know it's not all of the testing that's being done. So we didn't really want to use that to calculate a positivity rate because it wasn't complete. That was probably more than you wanted to hear, but there are some communities that are using that. We have chosen to look at lots of things because they're so intertwined.
Thank you. That's very informational. I think some of the emails that we get speak to just what Dr. Hurt was talking about, and that is, give us some sort of objective sign as to when things might ease up. And positivity has been used in some communities, but I think our 5 benchmarks are a more precise tool. So it would be all of those 5, I would imagine. Is that what you, Dr. Buchanan, would think would drive a decision?
Yes, that drives our decision making, along with all the contextual information about, where the cases are. If we don't have a jail, or we have a jail, we don't have a prison, but if we had a big outbreak in a prison, that is interpreted differently than if we have a big outbreak in a school. those are two very different locations to have an outbreak. So we also add into that our expertise and knowledge about the contextual information about the situation locally into those decisions. And I think the thing I want people to hear is COVID is not going away. And we're all going to have to be practicing the 5 core actions for many, many, many months. So COVID's here to stay. We have to learn how to live with COVID. We have to learn how to keep the number of people who end up in the hospital and dying from COVID down. And the way we do that is by all of us working together and practicing the 5 core actions.
Thank you. Any other discussion on the Knoxville UT Medical Center update from Dr. Shemaya? If not, thanks very much for another really useful report, good report. If there's no other discussion on that, our next agenda item is item 8, which is the COVID-19 suppression bars regulation, which is listed as 2020-3. And I may want to have Mr. Sanders just speak to that, because that 2020-3 was superseded by 2020-4, and that may be the one we should be discussing this evening.
It is. 2020-4 is what you should be discussing, and that is the provision that is currently in effect. 2020-3 was superseded by 2020-4. The difference being 2020-4 is the curfew provision, whereas 2020-3 closed the bars altogether.
So I am looking through my stack of papers here on 2020-4. Did 2020-4 also have a sunset date on it? I think it did, didn't it?
It did, tomorrow, or tonight at midnight, really.
Tomorrow, tonight at midnight. So that is going to be then germane to our discussion.
So I'll, I guess, just start off that I think with the returning of all of our college students that I think I'd like to see this stay in place for at least another 2 weeks and then review it again.
Other points of discussion? Maybe Mayor Jacobs, have you had input from the business community on this, and what sort of input and thoughts do they have about the 10 p.m. curfew? I'm sure it's affecting things negatively as far as their bottom line. Is it something that they're living with? Is this something that's untenable? What's the thought in the business community? We've heard some from our emails, but not a lot, really.
Yeah, and of course it is impacting, but I think that overall that they were content at that when we moved from a closure to a curfew, and thought that was a good move. So I haven't really heard a whole lot more after that. And of course, we're all hoping to get back to as normal as possible, as quickly as possible. But in this case, there hasn't, to my knowledge anyway, and you guys may have received more emails than we have, but there hasn't been a whole lot of reaching out from that sector of the economy.
I would like to say that I have received, I believe they were just to all of us, but some may have been specifically sent to my work email at UT, but I received feedback from bar owners who are pleading that this type of restriction also apply to all seated alcohol sales after 10 p.m. So in other words, restaurants and I'm bringing that up because that's been some of the feedback that's been very poignantly posed to me, and I believe all of us on the board. So that's another perspective, not complaining that they have the curfew, and in fact, talking about how they're trying very hard to adhere to the 5 core and, hanging in there. trying to follow the regulations, but feel like the regulations, the restrictions are a little unfairly or perhaps lopsidedly applied to bars solely and not all places who serve alcohol seated after 10. For what that's worth, I think it's worth discussing.
Any other thoughts or discussion on continuing sunsetting 2020-4?
I tend to agree with Dr. Sousa. I think another 2 weeks would be a reasonable period as we move forward, looking at the opening of college locally. And we also may need to look at some other ways, if we have any upticks in expanding this slightly, if we need to certain other types of businesses, but the preference is not to expand, not to cause problems in our business community as best we can, and to keep people safe.
So this is Dr. Buchanan, just quickly, if anybody's, regarding the data, we talked about, targeting bars due to the age demographic that we were seeing some increased cases in. And what I would say is that's kind of leveled off over the last few days. It hasn't, or last few weeks. It certainly hasn't gone down, but it's not gone down very much. It's gone down very little and remained pretty consistent. We've only had this in place for 16 days, to be honest. So, given what we know about trends and how we can see effects with COVID, we certainly don't have enough time to even know if it's been effective in reducing case rates among the population that would go to a bar. And in addition to that, the enforcement piece has really been not a big deal. There have been 7 complaints. And upon discussion, there was only one person who was out of compliance and the others were in compliance. So that's been, hasn't been a big challenge for our staff in that way. So just that's kind of the data around this particular regulation.
If I may, that reminds me, Dr. Buchanan, for my own understanding, because we get emails, as you know, from people saying, well, they're upset, they want to file a complaint against someone that they believe isn't, a business that isn't adhering to these regulations. Can you just, for my own education, tell me how a citizen goes through that process? Because obviously they're appealing to us, but that's not the Board of Health's, that's not our job. So
Right. So the best way for people to file a complaint about a business regarding COVID-19 regulations is to call 311, and 311 and the city and our staff are working together to follow up on those complaints. So that's the best place to get action taken. If you want a business to be educated or, visited by someone either from the city or from my staff, 311 is the place to lodge those concerns, and action will be taken regarding that.
Great. Thanks so much.
Dr. Buchanan, this is maybe just very slightly off topic, but I just thought of it and it's pertinent to prior discussion, is that, so back to the contact tracing piece, and whether it's 9:30 at night or 10:30 at night, if you're in that 48-hour window and somebody says, yeah, I went to establishment X 24 hours ago, then I guess from a contact tracing perspective, though, other than the party they were with, you really don't know who might have been exposed. So then it really gets back to those 5 core actions. Were they 6 feet apart from those people that they didn't know? And, and I guess a lot of that is some of these environments are more likely for people to wear masks than others. But I guess that's an inherent gap in contact tracing, right? It's just, you can only know so much. In place, if you know who was seated and you know who they were, where they were, that's one thing. But in these more public places, you just don't know. Is that right?
That's correct. And but the other piece to that is as we get new cases, we don't necessarily we're not finding a history of, a lot of people went to this one place, that where a lot of exposure occurred in one place. Now we're seeing that in other places where we know we have a lot of exposures occurring in one location with one particular group, but not particular to restaurants or bars. We have had some clusters among staff, but those have been very limited among retail establishments and or bars or restaurants. They've managed those really well and been very cooperative with us and kept those numbers very low.
And so last question, I'm sorry, but in follow up with your 233-ish contact investigators, are they connected enough that if 6 of them were to all find that these 6 people all went to X place, that they connect those dots? Because that's a lot of people doing those contact investigations.
A lot of people. We are actually using technology to help us do that. It's much more efficient than it has been in the past. So we use technology to communicate about what commonalities that we're finding and look at the databases. Also, when we enter the data into the state system, that information is entered into that as well. The state is looking at that data as well. And sometimes they'll come back and say, hey, we found, Knox County and East region, we found some commonalities that you guys didn't see. So that does happen. We can certainly miss that. We also have regular meetings and powwows with our staff to kind of keep up with that. So there's a lot of communication going on. The Teams page is very busy with communication, and I'm still learning how to use it. There's a lot of information in there, but it's been a very, very helpful tool, allowing people, Lisa's smiling because she's using Teams and loving it. People to be off-site and communicate back here with our staff so they can look at what's going on as well. So we're doing everything we can to keep track of that. Certainly, I imagine we do miss some of those.
Okay, thank you very much.
Sure.
Dr.
Dr.
Goetsch, you're muted, Dr. Goetsch.
I'm sorry. I just keep muting myself. Sorry about that. Thank you. Any other discussion on 2020-4? Remember that if we leave this as a discussion, it will sunset tonight. So if there is a mood of the group to continue this, we'll need a motion and a second to do that, and then we can discuss that further.
I'll make a motion to extend it by 2 weeks.
And I'll second that to go to September 3rd.
Okay, so we have a motion and a second discussion on the motion. Any discussion at all? We will revisit if this passes. We would then in early September revisit this and go through this again, which I think is a prudent process. If there are no other discussion, if there is none, we can call a roll call vote. Dr. Buchanan?
Absolutely. Dr. Drake?
Yes.
Dr. Goetcher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs?
No.
Dr. O'Brien?
Yes.
Dr. Souza?
Yes.
And I skipped you, Dr. Shamia. Dr. Shamia?
Yes.
And Ms. Wagner?
Yes.
Okay. So passes 1, 2, 8 yeses with 1 no.
Very good. Thank you. So we're now on topic 9.
I
which is
need to
other
correct
business.
myself. I'm sorry. 7 yeses and 1 no. That didn't sound right. 7 yeses and 1 no.
Picked up a new number. I got it. Okay. Thank you, Dr. Buchanan. So the next item in the agenda is other business, and one thing that I would like to bring up is the following, and Mr. Sanders, I guess this is probably appropriate to talk about our meeting that we're supposed to have in Nashville next week. Is that appropriate?
You certainly can. There's nothing to keep you from it. It's
Okay.
public knowledge.
Good. So Dr. Buchanan and I have been invited to participate, testify at a joint government operations meeting that's going to be chaired by Representative Martin Daniel in Nashville next week, August the 26th. And it may or may not coincide with the time of this meeting. Our part may be short or may not be, I don't know. It's going to start about 1:30 Central Daylight Time, which is 2:30 here. And it's in with several other agenda items. So I don't know whether we're going to be participating in that for an hour or for 2 hours or maybe 15 minutes. But I think we need to have a contingency plan for another chair for the meeting next time. I will be in Nashville, as will Dr. Buchanan, and I'm assuming that both of us would be able to participate by Zoom from Nashville, but it might be a little tricky to try to chair that meeting from Nashville. I mean, if I had a bad connection or if we were delayed in testimony, it probably would not work. So thoughts from the committee, is this something somebody would like to step up and do? Do we need a vote on this? Can we do this as a chair's prerogative for an appointment? How to proceed on this? And I guess we can start with just discussion from our members.
Just in a related item, last week we did entertain the idea of going to every 2 weeks. So that might need to be decided first, whether we're going to go to every 2 week meetings or we're going to keep the weekly meetings. Just looking back over last month's minutes.
We had a discussion about that, and it was interesting that there was, I won't say a considerable amount of feedback, but certainly some feedback from the community on that. And I will just say that at least my interpretation of the community feedback was keep weekly meetings. But it would be the prerogative of the committee to determine how often we would be meeting based on the acuity of the problem. So we can have some general discussion about that, but if there's a thought for either keeping them weekly or maybe keeping them weekly, I guess would not require any further action, but going to bi-weekly would probably require a motion in a second.
So one thing I would mention as far as if we skipped a week, I mean, again, I don't know that has to be a long-term decision. I mean, if, I was the one that originally suggested we transition to weekly because of the trend of the data. The other thing, if we did choose to not meet next week, even if that wasn't going to be a longer term decision, I could certainly still share data with no intent of discussing by email, but just if that was appropriate, present data. I would think that what I wouldn't want to do is go 2 weeks and people just be caught off guard by, for example, hospital data that they hadn't looked at in 2 weeks. So I think there'd be value in that regardless. I'm certainly willing to go either way. I would hate though for us to have a meeting and not be intact as a full group if for some reason your trip went sideways or there just were issues. Regardless of who was chair, I would not want that. So we could still review data and not formally meet.
In discussion with Mr. Sanders on this point this afternoon, if by some quirk, Dr. Buchanan and I were both completely unavailable for the meeting, you'd still have a quorum if everybody else were in attendance. So it would be possible to conduct business if you needed to. My personal thoughts on it are this. As an informative and deliberative arm for the public, and with some restrictions in play right now, I think that getting weekly information is valuable to the public. I think that it is, at least by what we get. I know we probably get a biased sample through our emails. Not everybody that thinks about this has probably emailed us. But I mean, that's kind of the gist I got. I don't think I've heard from anyone that said, "Oh yeah, you're meeting too often. Just meet every month or every 2 weeks." In fact, I know we've all gotten emails that said, please don't meet bi-weekly, meet weekly. We need the information. So that would be my bias. That's one member's bias.
I actually agree with that. When I brought that up last week, it's a way of having a point of discussion. Are we at a point, I think the public has told us, and we know that it is good for us to go over this data, to let the public know what's going on, and to continue to do so until we reach a point at which we have really gotten on the downward trend. I mean, we are just starting, and people need to realize this is not the point to take our foot off the gas. This is just the point where we keep moving and keep doing the 5 core actions. So I'm actually in agreement with weekly meetings until such time as we get way down the road.
I agree. I think we need to continue weekly, not only to reassure the public that we are paying attention to the data, that we're paying attention, but also because, as you all know, today was UT's opening day of classes, and we've already had, this is public knowledge, Chancellor Plowman already announced yesterday that we've had our first cluster, which was initially 5 students. Now it's over 20, and an off-campus gathering, a party. So that monkey wrench is now thrown into the variable. So my concern is if we skip next week, and it can happen because we've already begun to see the results of students coming back to campus even before classes have started. So I don't see any reason not to meet weekly, other than I recognize that you all, like me, we all have full-time, very demanding jobs. So there's that, but I personally and professionally am willing to meet weekly until we don't need to anymore. But if nothing else, it's a real reassurance to the public that we are paying attention, because that's the feedback. That's how I interpreted the feedback as well, is they want to be sure. My thoughts.
I think from an electronic standpoint, as long as we are not in active testimony, I don't think we would be, but as long as we are not in active testimony, Dr. Buchanan, would you have capability to Zoom meeting through a laptop or phone over in Nashville?
Yes, I would.
Okay. So I would as well. I have family in Franklin, and even if we finish early, I can go back to my daughter's place back there, and it would be easy to do. It would not be difficult. But on the outside chance that we can't do that, or that there's a glitch, it would be nice if we could have a temporary chair or a vice chair. And when I talked with Mr. Sanders this afternoon, he brought up the idea that our daily occupations sometimes are going to lead us in all sorts of different directions where we may not consistently be available. And so having a permanent vice chair might be a reasonable idea, or maybe something to think about. But if we want to think about that and come back later, we might need somebody to at least volunteer for next week, just kind of to be on the safe side for Dr. Buchanan and myself. Thoughts about that? Anybody willing to step up to the plate?
I don't mind doing it. I've done it in the past, so
You did a great job.
I don't know that if everyone's okay with that. I don't need to be a vice chair yet. We can discuss that later, but I could do next week as a chair if need be. And I guess one thing to ask, maybe if Martha, if you could have a backup just in case there's some sort of snafu, if there's someone actually in the health department that could present those, the 5 stoplights just in case.
Absolutely, we got it.
Any other new business or other points of discussion in our final agenda item? Dr. Buchanan, any other things that we needed to touch and go over?
Not that I'm aware of. Oh, yes, sorry. We just need to talk about we won't know this by next week, but August 29th, the governor may not renew the ability to meet virtually for boards such as ours. So we'll need, there's some logistics to figure out with where we can hold this meeting on a regular basis. Well, we will start looking at options of what rooms are available that will accommodate the needs that we have. So just we, the health department will start looking at that. But just to be aware, we may be meeting in person in September.
Thank you. August 29th is the expiration of that executive order if nothing else is changed. Is that correct?
Yes.
Okay. Any other discussion, any other things to go over for this week?
I just had one thing I wanted to bring up, and I don't necessarily need a resolution right now, but I just wanted to recognize that in our emails, I don't know if everyone has managed to filter through these and find these, but for I guess like the last 3 weeks, we've consistently gotten emails from employees at some of our local gentlemen's clubs asking for us to address some of their issues because they're, I guess they're concerned about the health of the workers at those places because they don't fall under the bars because they don't actually sell alcohol. It's a BYOB situation. And so I guess I'm not asking for a solution. I want to recognize that we hear you and that perhaps that's something that we need to think about how to incorporate that into what we've already got on the books.
As a point of discussion, we are working on that. Mr. Sanders and I talked about that a little earlier today, that it may involve just some modification and wording of what we already have as to how alcoholic beverages are procured, served, and so forth. So that may be something that might come up next week or the week afterwards.
Okay, thanks.
Thanks, Dr. Sousa, for bringing that up. I want people to know we really do our best to read the emails. Sometimes we just don't have a quick answer because. But I appreciate you, Dr. Gotcher, in looking into that as well.
Yeah.
Thank you.
I think it's a legitimate concern, at least.
It is as
It needs to be discussed, needs to be discussed. Any other business to come before?
Dr. Gotcha,
Yes.
what can we do about them not wearing masks at those gentlemen clubs?
I don't know. I don't know how they're regulated. The business model, Mr. Sanders and I talked about this earlier today. The business model is such that they do not fall under ABC guidelines. They do not fall under beer board guidelines. They do not fall under restaurant guidelines. I don't know which guidelines they fall under. Myself, I'm not an expert at all at that, that business side of things. So I don't know.
Dr. Goodcher, if I can
Yes.
weigh in some here. Basically enforcement of any of the Board of Health's regulations falls under two separate lines, if you will. The first is through law enforcement. That is the breaking of a regulation of the Department of Health is in itself a misdemeanor, a criminal offense. So in as much as any of the law enforcement community choose to enforce it, there is that option. And that would be KCSO within the county, KPD within the city, and UTPD on campus. Now, as far as what happens outside of that, the Tennessee Code does give Dr. Buchanan, in both her roles as health director and health officer, certain powers over business establishments, which if she chooses to exercise them, she can. Now, of course, a tricky part of the situation is described here is finding out whether there is in fact an infraction. But if we know of an infraction and it can be proven, there are powers that Dr. Buchanan has as health director or health officer for the county, which she can undertake. And if she did, she would do that with the assistance of our office.
And I will say that going down the route of taking action as the health director is complicated, and you have to really be sure of going down that route. That's why we've really chosen to prefer to educate and inform as opposed to regulate and close down. Folks who are concerned about the activities that are happening and lack of mask wearing anywhere, again, I go back to call 311, and in cooperation with the city and my staff, they'll go out and visit those locations and discuss with them how to be in compliance.
Thank you. There's one other point I would like to bring up just as a matter of information to our group, and also maybe as a matter of information to the public, because we've gotten occasionally email messages that say that we are unelected, which is true, and that we do not, by law, have any powers to do anything other than advise. And I want to call everybody's attention, and I'll thank Mr. Sanders, as he did a great job of getting me through this afternoon, that the Tennessee Code Annotated has got a specific regulation as to how boards are set up, the members that constitute the board, and what their powers and what their duties are. And so I would, we can probably send this out to everybody, but the TCA code is 68-2-601, paragraph F123. So that's the note if you want to look it up. And all of that is available through Tennessee.gov. The whole TCA stuff is on there, but that's a law that set all that up. And it was actually set up in 1985, and it's had a number of iterations since then. And I believe, if I'm right, Mr. Sanders, the last iteration was 2003. So it's been around for a long time. This is how all the health boards may be set up, but certainly in the larger counties throughout the state.
Yeah, that's essentially correct. I can't speak offhand to what the previous versions of the statute read, but it does not appear to have been amended since 2003.
So it's been a law for quite some time, and it's basically how things are set up, and it also describes the duties and the powers of the board. So it's not, at least by our discussions, Mr. Sanders, you can kind of chime in if I'm not stating this correctly, but it seems that the intent of the lawmakers in setting this up was actually to keep some distance between the election process and the health department deliberation process. In other words, they wanted to have professionals that were appointed for their professional skills to debate and decide these issues rather than having those professionals elected. Is that a correct statement?
I wouldn't want to speculate on the record here without studying the legislative history. A lot of statutes like this will have legislative history, which would explain what was in the mind of the legislators when they drafted the legislation. I don't have that at my fingertips. What I can say is, if you read the plain language of the statute, it delegates who comes onto the board. It says, for instance, 2 physicians that are nominated by the medical society serving that county, a dentist nominated by the dental society serving that county, and so on. There is not a process, obviously, for popular election of members of the board. The only member of this board who is popularly elected is Mayor Jacobs. Beyond that, everyone is appointed by the county commission, which is an elected body itself, from nominees of these various professional societies, and the other exception being the director of schools or his designee.
So kind of a refresher course on the law that directs our deliberations. So any questions about that? I'm probably not the one to answer. Mr. Sanders may be, but if not, I leave that just as a kind of a point of discussion. So we kind of have some, I guess, sense of moorings or what directs us, I guess, but legally directs us.
Dr. Gotcher,
Yes,
can you repeat that Tennessee code annotated again?
I sure can. It's TCA 68-2-601, and then in parentheses F, and then in parentheses 3, but it's really F1 through 3. Just describes the duties and the process of selection of members of boards of health throughout the state.
We can get that out to everybody.
Yeah.
Thank you.
Maybe not this evening, but tomorrow.
Thank you.
Any other information or business to come before us this evening? If not,
Dr.
Yeah.
Roger, I would just like to tag on to what you just brought up, if I may.
you may.
I want to thank you for bringing that up. We on the board, of course, get lots of feedback from the public, and we do appreciate it. I think several of us have said that many times over the course of our meetings. I mean, hundreds of emails over the course of the past month or so. And that is part of the feedback, as people are confused and feel very strongly that they believe we're elected and that we should be unelected or booted out of office, or they know we're not elected and feel therefore that we do not have a legal right to be where we are doing what we do. So I'm really glad that you brought up Tennessee Code Annotated. And I also want to just remind us as a group that our previous legal counsel, Myers Morton, reminded us frequently of our legal responsibilities to our community and the safety of our fellow citizens. And I'll quote him: "You all are scientists. You are on this committee for science. It's not political. 200 something emails are irrelevant. As somebody once said, when politics and science combine, there is no more science. So you all are scientists and your decisions need to be based 100% on science." And I just want to reinforce that's exactly what we try to do every week when we meet, as well as in the days and hours in between our meetings.
Appreciate those comments. Anything else to come before us this evening? If not, we can accept a motion and second for adjournment.
I'll motion to adjourn.
Second.
Well, thanks for your participation and all your efforts, everyone. And we will meet next week at 5 o'clock. And Dr. Buchanan and I will probably be in Nashville when we do that meeting. But we will see you all then. Thanks very much for everybody's help.
Thank you.
Thank you.